Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today some more important rules in the clinical care tips category. Rule number 126. Start with the end in mind. So as I have discussed before, as a pediatric emergency doctor or emergency doctor, I see myself as having two important jobs or two important roles with every patient that I see. Essentially, there are two things that I always have to do. Number one is acute care, give the patient what they need, be it CPR, IV fluids, oral fluids, Zofran, or maybe just Motrin, or maybe just even reassurance. And the second thing I have to do is decide the appropriate disposition for each and every one of my patients. In other words, is this abdominal pain potentially surgical, serious, and I need to keep the kid in the hospital, or can this child go home today? Sometimes, however, it's easier to start with the end in mind. Start with the second question, can I discharge this kid home today? The reason is because sometimes it's simply very obvious. This child can go home today or this child cannot go home today. Oftentimes, when I think the child needs to be admitted, I think it's a good idea to set up the expectations and talk to the parents about it early. A good example I can think of is the child that is coming, let's say, with an abscess that the primary care maybe is drained, maybe even treated with antibiotics. The child is taking the antibiotics, not vomiting or anything, and the abscess looks worse. In the emergency medicine community, we call this situation failure of outpatient therapy. If the kid had the abscess drained, has taken the antibiotics, tolerating the antibiotics, the only possible thing I can think of is that the patient needs an IV antibiotics. This is assuming, of course, that the patient got the appropriate antibiotics the first time. For example, if we're talking about an abscess, something like clindamycin as opposed to just amoxicillin. But essentially, if the patient has done everything they could and the caregiver followed up with PCP, etc., I would consider that failure of outpatient therapy, and that patient should probably come in. The reason I start with the end in mind is that I think parents appreciate communicating that to them early. So, mom and dad, you've done everything you could. You've given the antibiotics, your child is taking the antibiotics. Seems like the primary care drained it and did the best that he or she could. I think that leaves us very little option, and unfortunately, little Johnny needs IV antibiotics, and therefore we're likely going to admit you to the hospital today. So I just want to communicate that to you early so you can just be aware. Another good example is the kid that comes with moderate or even severe asthma exacerbation, and when I take the history, I learned that mom has been treating this with albuterol every 4 hours for the last day or two, let's say. As I've discussed in the podcast before, getting a good story and getting a good HPI is very important, and when I ask that question, if the mom or dad tell me that the child has been taking albuterol in what seems like an appropriate dose every 4 hours, and despite that he is in moderate distress, I always tell the parents that there is a chance the child might have to stay in the hospital today. And to me, it's a very logical and easy thing to think about. If the child you're seeing in front of you is in moderate distress, and mom and dad have been giving albuterol every 4 hours, let's say for the last 2 days, all you're going to do today is give more albuterol, steroids as well, sure, but essentially his beta receptors are saturated with beta agonists. I'm not sure that the treatment I'm going to provide today is going to make a very big difference. He's already taking the same medication I'm about to give him. Sure, I can give magnesium and I can give IM epinephrine, but certainly a child that received those medications should stay in the hospital. So remember rule 126, start with the end in mind. When you see a child with moderate asthma exacerbation that has been treated at home and has been treated appropriately, plant the seed and communicate to the parents, mom and dad, I think your child might have to stay in the hospital today. I apologize. When you see a child that had an abscess drainage, has gotten antibiotics, is taking the antibiotics, make sure the parents are aware. Mom and dad, I probably will treat your child with IV antibiotics today, which means he or she have to stay in the hospital. I'm sorry. I think this also helps you make that decision early and make the appropriate arrangements early, communicate to the hospitalist, etc. So remember rule number 126, start with the end in mind. Sometimes. Rule number 127, I'd like to give Fatima Levent, my colleague from Orlando, the credit for that rule. I've spoken to her many times, I've spoken to her about fever many times, and this is something that she says she tells the parents. Celebrate the fever. So this goes back to really basic immunology and keeping in mind that fever is a normal immune response that under many circumstances is actually beneficial. Specifically this season we're seeing a lot of influenza, and I am aware of 2 studies that indicated that kids who are not treated for the fever as much actually recover from influenza, specifically influenza, faster. And this study, like other studies, basically indicates what we kind of know but maybe are in denial, that fever is part of the immune system. And it's good and it's beneficial. By all means, it comes with a price. So I always tell the parents, if the fever causes a headache, if the fever causes muscle pain, if the fever causes the child to be cranky, not drinking, not resting, not sleeping, by all means, treat the fever. But mom and dad, keep in mind that fever is a normal response. And if your child has a fever, that shows that the immune system is working. Celebrate the fever. Going back to the American Academy of Pediatrics, that says that antipyretics should not be used for the sake of keeping the child normothermic, but should be used for comfort. A child with 104 temperature who is already comfortable does not need antipyretics. Sure, they need fluids, they need rest, etc., but celebrate the fever. If your child has a fever, make sure the parents understand that is a normal response, that is a response that indicates he or she are mounting an immune response, and that is good, normal, and possibly beneficial. If the child is not complaining, less is more. Rule number 128. 20, 15, and 10, 15, 10, and 5. Oh, this sounds a little confusing, I understand, but this is a rule I learned from Sean Keys, from pediatric orthopedist, who has been on the show before, and this is the rule that helps you figure out, does your child with a forearm fracture need reduction today, or can he or she be splinted and sent to the outpatient world? So the numbers I just told you refer to the angulation of the forearm for kids less than 10 or kids over 10. As we discussed in the podcast before, with Sean Keys, bone healing has to do with bone growth. And kids, especially younger kids, unlike adults who have a lot of growth potential ahead of them, can recover from fractures very well, and often those fractures can be splinted and left alone. How do you figure out if this fracture can be left alone with a splint only, or does this child need sedation and reduction today? Requires a little bit of experience, but the following rule I heard from Sean Keys can help you figure that out. So for kids under 10, you can tolerate angulation of 20 degrees, 15 degrees, or 10 degrees without reduction. The 20, 15, and 10 refer to the location of the fracture. So as we know, anything that is closer to the growth plate has a better remodeling potential. So 20 degrees at the distal fracture, 15 degrees in a fracture that is in the mid shaft, or 10 degrees in a fracture that is proximal in the forearm can be tolerated for a kid that is less than 10 years of age. Kids that are over 10 years of age, as we discussed, older kids can tolerate less angulation, so the rule for them is 15, 10, and 5. They can tolerate 15 degrees of angulation distally close to the growth plate. They can tolerate only 10 degrees of angulation in the mid shaft, 5 degrees of angulation in the proximal forearm. So again, for kids less than 10, 20, 15, and 10, they can tolerate 20 degrees in a distal fracture, 15 degrees in a mid-shaft fracture, and 10 degrees in a proximal fracture. For kids over 10, the rule is 15, 10, and 5. They can tolerate 15 degrees in a distal fracture of the forearm, 10 degrees in a mid-shaft fracture of the forearm, or 5 degrees in a proximal fracture of the forearm. Those are the numbers you can maybe discuss with your radiologist, and if those are the numbers you're seeing in front of you, that can help you figure out if your child needs sedation and reduction, or can he or she be splinted and sent to the outpatient world. So remember Rule 128 for reduction of fractures: 20, 15, and 10 in kids less than 10, 15, 10, and 5 in kids over 10. Thank you, Sean Keys, for this rule, and thank you for helping us figure out, do our patients need sedation reduction today, or can they be splinted and sent to the outpatient world? And that is it for today, guys. Thank you very much for listening. Let's review what we learned. Rule number 126. Start with the end in mind. Sometimes it's helpful to figure out ahead of time, is this patient going home today or is this patient staying in the hospital for whatever reason? Oftentimes, if you have made that decision, you can move faster, mobilize your resources faster, and communicate to the parents sooner. Mom and dad, unfortunately, I think your child might have to stay in the hospital today. Rule number 127. Celebrate the fever and teach the parents to do the same. I think us as physicians should communicate to the parents and send message to the parents that fever is not dangerous, it does not cause brain damage, and it's rarely the reason to come to the emergency room or even seek medical care. If your child is hydrated, breathing comfortably, fever in and of itself is rarely the cause of the concern. Make sure the parents understand that fever is a normal immune response and really indicates that the child's immune response is working. Celebrate when your child has a fever. Rule number 128. Rule of reduction for forearm fracture. For kids under 10, 20 degrees, 15 degrees, or 10 degrees, distal midshaft proximal. For kids over 10, 15 degrees, 10 degrees, or 5 degrees. Again, a child that is under 10 can tolerate 20 degrees of angulation distally, 15 degrees of angulation in the midshaft, or 10 degrees of angulation in a proximal fracture of the forearm. A child that is over 10, unfortunately, can tolerate only 15 degrees in a distal forearm fracture close to the growth plate, 10 degrees in the midshaft, or 5 degrees in a proximal fracture. I hope these rules help you manage your patients better, and I hope you find the podcast helpful. Please submit any feedback you have to pemrules.com. I love hearing from you guys. If you applied PEM rules at work or if you thought of any rules of your own, please let me know. Maybe we can bring you up for the show and talk about it. So again, thank you for your support. I hope you like this solo by Nirvana. Smells like Teen Spirit.